Columbia University is a very prestigious institution worldwide. So it does mean a lot for me to be here. We're going to be talking about my favorite topic in periodontology, which is aesthetic crown lengthening and how to improve its predictability with digital workflows. Um, just a brief introduction about myself. I graduated dental school, European Federation of Periodontology accredited program at University Complutense of Madrid, where you guys are more than invited to come and visit anytime you want, where I'm currently doing my PhD and working as a collaborating professor in the program. And then I also did 2 years at the University of Michigan as an ITI scholar and adjunct clinical faculty. This is my home here in Madrid, our university. Like I said, you guys are more than welcome to come whenever you want. It would be our privilege. And from here, I crossed the pond in 2023, where I actually met many of you in 2 wonderful years at the University of Michigan, where we refined the protocols that we will see today. And it was a great time. I enjoyed the few months where it was good weather. I didn't enjoy so much the months where it looked like this, but I'm sure you guys have pretty deep winters in New York as well. So without further ado, we're going to talk about digital workflows in aesthetic crown lengthening. And for every presentation, every topic, I like to answer the questions why, how, and what. And the way that we're going to approach this presentation is first, we need to understand the why. Why does this condition happen? And why do we need to treat it? We need to, as periodontists, at the end of the day, we need to have the knowledge in our minds. We need to have the technique in our hands because that's what we're going to end up doing, treatments. And with research, and you're in a very research-based school, we can see the limitations of our current protocols and how we can improve them in the 21st century, of course, with digital workflows. So as a brief introduction to introduce the topic, why I became so passionate for periodontology is that because most of the time we do treatments to patients where we leave them sometimes aesthetically impaired. We have long waiting times until the patients see the benefits of our treatment. However, these type of patients that are self-conscious about their smile, like Denisa, that come with a chief complaint that they don't like their smile, that they show their gums too much, or that their teeth are too short, is what really motivated me to drive into this treatment. So all the time, I wish we're in the same room and I could throw these questions to you, but try to answer them in your mind. What you're going to see in your clinic is a patient, most of the times, that comes with short teeth. So we're going to be asking ourselves questions that hopefully at the end of the presentation, we're better at answering. We need to ask ourselves, why are the teeth of the patient short? And does she just have short teeth? And those are the teeth that she needs to deal with in her daily life. Or are we able to lengthen them with crown lengthening? And mostly, is this going to be stable for the patient throughout her lifetime? So the first question that we're going to answer is the why. Why does this condition happen? And I'm very sorry, but we need to go back to anatomy and biology. And so that we understand the digital workflows and its benefits, we really need to understand the basics. However, we're pretty short on time and you guys are all perio residents. So we're going to really fly through this first anatomical introduction, which is relevant to crown lengthening. We know the basics. We know the components of the periodontal ligament, or I hope that everybody in this group knows them. However, we're going to go a little bit deeper into the histology. And we need to understand because as periodontists, most of the surgical treatments that we're going to do are going to be with a blade in our hand. And to obtain ideal outcomes and ideal healings, we really need to understand exactly which tissue our blade is going through at each time. So what histology becomes very relevant to aesthetic crown lengthening? From a more external point of view, let's all go back and remember that we have gingiva and alveolar mucosa that are separated by the mucogingival junction, and that gingiva can be either attached gingiva or free gingiva, or it's not attached. So now if we go more in detail, what do those attached tissues look like? We have the connective tissue, which is attached to the root of the tooth, and also the part of the epithelium, which is the junctional epithelium that is also attached to the enamel. And we might ask ourselves, why is this relevant? Because any single crown lengthening treatment that you do in your clinic, in your life, will be dependent on the relative relations of these four anatomical structures: the free gingival margin, the cemento-enamel junction, the alveolar bone crest, and the mucogingival junction. And this gives us all the information about the diagnosis, treatment planning, and execution. And you guys are also probably familiar with the term of the biological width. Now we call it supracrestal tissue attachments in the World Workshop in 2018. And it is the apicocoronal variable dimensions of those tissues that are attached to the tooth, composed, remember, by junctional epithelium and the connective tissue attachment. And the million-dollar question is, how much does the biological width measure? Well, as you probably know, there's been a lot of classical studies that have looked into this. And on average, in a healthy periodontium, the connective tissue is very stable, always around 1 millimeter. The epithelial attachment is 1 millimeter, and that sulcus remaining is around 1 millimeters. So our supracrestal tissue attachment is going to be, on average, 2 millimeters. And if we add that 1 millimeter of oral sulcular epithelium and gingival sulcus, we're going to have a distance, remember, on average, from the free gingival margin to the alveolar bone crest of 3 millimeters. So this is always going to be a very relevant intersurgical reference that we're going to have during our crown lengthening procedures. And why is this so important? Because the body has its rules, and the biological width is the rule and the distance that the periodontium likes to keep. If we don't respect these rules, we're either going to have gingival inflammation, bone loss, or gingival recession if it's a thin phenotype, or if not, soft tissue rebound. So when a patient comes with short teeth and we ask ourselves if we can lengthen them, we are starting to talk about what a crown lengthening is. And the definition is very self-explanatory, is when we want to increment the availability of the supragingival sound tooth structure by removing the gingival margin apically. And that we can do by removing gingiva, or sometimes also combining it with the removal of bone. And this can be done either for functional or, as we're going to talk today, mostly aesthetic purposes. So we basically want to make the teeth longer. And what are the principles of crown lengthening? What we want to do is expose sound tooth structure that is previously covered by gingiva. And this can be done in two very simple steps. Step number one is gingivectomy, removal of soft tissue. And step number two is osseous surgery to remove hard tissue. And once again, we need to always make these two simple steps while respecting the biological relationships of the body and of the patient. So how are we going to be predictable in our treatment? Just by individualizing each case based on a proper diagnosis. Gingivectomy is a very simple procedure. We're going to do paramarginal, usually incisions, always trying to remember 2 millimeters of keratinized tissue width, because teeth like to have at least 2 millimeters of keratinized tissue width. We've seen throughout the literature that it's not completely essential, but if we have it, let's just not remove it. And is gingivectomy enough? It is enough in some cases if the supracrestal tissue height is respected. So we go back to the importance of a proper diagnosis. Step number two, do we always need to do osseous surgery? When do we need to do osseous surgery? Well, let's first understand the aims of performing osseous surgery. And the main aim is to eliminate bone to allow for the establishment of that supracrestal tissue attachment or biological width in a more apical position. But since we're already raising a flap and we have exposed the bone, let's just also go for the secondary aim of trying to create a favorable bone architecture to recreate ideal anatomical relationships. And this is done by two steps. So osseous surgery is a common term, and we can be talking about ostectomy, which is the removal of supporting bone, so that bone that is attached to the root by Sharpie's fibers, or osteoplasty, which is the removal of non-supporting bone. So of course, the area that is attached to the root will do ostectomy, and all that superficial and higher bone will be osteoplasty. Which do you think is more dangerous? Of course, ostectomy, because if we perform excessive, we can lead to gingival recession. And trust me, a patient that comes with a gummy smile and 2 weeks later has gingival recessions will not be happy with your treatment. So, as you can see, the steps to perform a crown lengthening are very, very simple. They're very simple skills that are, I'm sure, already to your abilities as residents of a perio program. However, all the relevant information is in the diagnosis so that we are predictable in the long term. So if Denisa comes because imagine her sister is getting married in a year and she wants to improve her smile, we need to start understanding why this is happening. And if we do a crown lengthening surgery and we don't respect the supracrestal tissue attachment, we just perform a gingivectomy, what's going to happen? 3 to 6 months later, we're going to have a soft tissue rebound and the supracrestal tissue attachment is going to reestablish. Your patient is not going to be very happy with you. And as clinicians, you're going to think that crown lengthening doesn't work, as I've heard many, many, many times. However, just by respecting the supracrestal tissue attachment and performing a biologically driven crown lengthening, you'll have long-term stability. Your patient will be very, very excited about their new smile. And you, as residents of the perio program at Columbia, just like I do, hopefully will love crown lengthening. So the first take-home message is that we need to perform crown lengthening based on biological principles, which as perio residents, I am sure that you know. Now, step number 2, and this could be the most relevant part. How do we diagnose, plan, and treat these cases of aesthetic crown lengthening in gummy smile patients? Well, first we need to understand what is a gummy smile. And this, each person could have their own definition, but by the literature, excessive gingival display, or what people commonly call gummy smile, is a non-pathologic condition in which more than 3 millimeters of gingiva are exposed while smiling, causing an aesthetic disharmony. However, if a patient comes to you tomorrow with a slight gummy smile, but they're very happy with their smile, don't go telling them that they have aesthetic disharmony and create a complex on them, because some people believe that having a slight gummy smile is part of their personality. And what is the etiology? Well, sadly, it's a pretty complex and multifactorial etiology, and it can be of either osseous components. If we have a vertically increased maxilla or a dental velar extrusion, we can have muscular components. If we have a lip hypermobility or a short lip, or what we're going to treat as periodontists, and we're going to learn now how to diagnose, is altered passive eruption, which we will correct with periodontal plastic surgery. So when a patient comes with a gummy smile, we need to do a comprehensive diagnostic evaluation regarding the medical history, the facial analysis, the lip length, the lip mobility, the tooth shape and size. And we're going to ask ourselves, does the patient have altered passive eruption? So to begin with, we need to start to understand the clinical signs that these patients are going to have. And commonly, they're going to come with very short teeth. Anterior teeth usually have proportions, ideal proportions of around 80%. So if a patient comes with teeth with square shape or 100% proportions, we can start to ask ourselves, why are these teeth short? And in many cases, it's going to be due to altered passive eruption, which is an abnormal dental velar relationship characterized by the gingival margin and sometimes bone located at a more coronal level. And something I'm going to share with you, I left my residency knowing very well what altered passive eruption was, but I had no idea, or I never thought about what passive eruption is. So when the tooth erupts, we have the active eruption first, in which the tooth goes through the gums to find its contact, and then the gum and the bone are slightly above the CEJ. However, when the tooth finally reaches its contact, then the gum and the bone recedes to its natural position, and that is called passive eruption. And if that doesn't happen, is when we have altered passive eruption. So based on this classification from Coslet and coworkers in 1977, we can classify the types of altered passive eruption. Remember, on those same structures that we saw in the beginning, the free gingival margin, the CEJ, the bone crest, and the mucogingival junction, which are the same anatomical references that we saw in the beginning. But now we need to see how can we detect these references clinically when this patient arrives and ask us if we can make their teeth longer. Which of these references can you see? Can you see the CEJ? Can you see the gingival margin? Can you see the alveolar bone crest? And how predictable are we detecting these references? Well, to begin with, we need to detect the CEJ. And I don't know if any of you guys have attempted to detect clinically the CEJ in patients with a thick phenotype and ultrapassive eruption. I've been trying for many years and I still haven't managed. So I invite you to try in the next patient that you can. And it's also an invasive process that patients don't like. So it's very, very complicated. What if we want to detect the alveolar bone crest? Well, it's not so easy in periapical x-rays since we have superimposition of the bone and the tooth and the CEJ. We can do some tricks. We can put some radiographic markers in the x-ray so that we can see the reference, but we don't have an exact distance between the gingival margin, the CEJ, and the alveolar bone crest. And how do we detect the bone? We can also do bone sounding. You'll know that when we do regular probing, the probe will go through the sulcal epithelium and to the end of the junction epithelium. However, if we want to reach the bone, we need to do bone sounding with a lot of power, and this is very painful and invasive for our patients. And of course, as you can expect, patients don't like you to have to put numbing just on the diagnostic phase. So we have clear that the treatment of these conditions is based directly on the relationship between the CEJ, the gingival margin, and the alveolar bone crest. But the traditional tools that we have to detect the relationship between these positions are not so great. And basically, this you can summarize it in this table, in which, based on the different types, just think, if you have enough keratinized tissue, you will perform a gingivectomy. If you don't have enough keratinized tissue, you will perform an apically positioned flap. And that's for the soft tissue component. For the bone component, if you want to lengthen to the CEJ, if the distance between your CEJ and the alveolar bone crest is adequate, you will not need osseous surgery. But if the alveolar bone crest is too close to the CEJ, you will need osseous surgery. So based on these four types, we can combine gingivectomy and apically positioned flaps with osseous surgery or not. The most common in ultrapassive eruption places is to have to do a combination of gingivectomy and osseous surgery. And here we have beautiful explanatory videos of all the steps: the gingivectomy, the removal of the scallops, the bone, osseous surgery, the ostectomy, the osteoplasty. However, this is not the aim of this presentation, so we're going to slightly go through it. But the take-home message number 2, which is very, very relevant. Remember, the first one was the importance of biology. And the take-home message number 2 is that we need to start from a proper planning, from a proper diagnosis to do a good treatment planning. And then it's just a matter of surgical execution. But what is most important, it's a proper diagnosis. So now for the cooler part of the lecture, we need to ask ourselves, what can we do with the technology that we have to improve our protocols? And something that I like a lot is to check the topic before trying to do research on the topic. And if we start looking at precision dentistry, personalized dentistry in the last years, there's been an increase of personalized solutions for different fields of dentistry. However, when we go to conferences in restorative or prosthetics or any other fields, we see a lot of digital stuff. However, we go to perio conferences and we see in the big podiums surgeries done like we still did them 20 years ago. So why is this happening with the available technologies that we have in our clinics? And I am sure that you have in the clinics of your program at Columbia. And these are not very new technologies. These are tools such as common as a CBCT, an intraoral scan, treatment planning softwares. Most of these treatment planning softwares now have some sort of artificial intelligence embedded into it, and CAD/CAM softwares that allow us to plan imprint guides for our treatments. So now we're going to see during the next 20 minutes, what is one of my favorite fields of research, and I think the more interesting part of the presentation. However, I wanted to lead you guys into the necessity of why we need this, trying to show the relevance of following biology and the limitations that we have with the tools, the conventional tools, to be very predictable in the long term. So now we're going to see how these digital protocols can help us all the way from the diagnosis to the guided therapy and long-term stability of our patients. And as we saw, gummy smile due to altered passive eruption is a very high clinical challenge because it's a highly aesthetic treatment. And one of the key steps is performing the right amount of osteosurgery. If we perform too much, we can create a gingival recession. And if we perform too little, we can have gingival rebound. And if we look in the literature, actually, there's a systematic review by Diaz and co-workers in 2014 that says that around 50% of the cases have some sort of rebound at 6 months. So that means that 1 out of every 2 patients that comes with a very self-conscious problem with their smile is not going to be very satisfied with your treatment. I've already tried to show you and demonstrate, but I invite you to try by yourself how complicated and sometimes it's impossible it's to detect the CEJ with a perio probe in these patients. And here's the slide that I was referring to, how we can see the high chances of gingival margin rebound. And also, now we know more information, and we know that the supracrestal attachment height can not only be standardized, should not be standardized, but can be individualized to each individual patient. So this is a protocol that we published at University Complutense of Madrid together with my best friend and colleague, Ignacio Pedrinazzi, with whom we do all of our research on digital workflows with. If you guys want, I will kindly send you the email to the email feed that we already have. And what we wanted to create is a full workflow, which we called MAPs, as multifunctional anatomical prototypes. So a map that just guides you through the whole process of aesthetic crown lengthening. And Dr. Chin asked me to see and showcase a case very in detail, each step from beginning to end. And this is what we're going to do with this case that we added to this presentation. And we're going to see how with digital tools, we can improve the diagnosis, the treatment planning, the patient communication phase that nobody speaks about, and also the surgical phase of aesthetic crown lengthening.
So just to give you Dr. Kalavetrova, it's marking around 30 minutes by now, so it's a great timing. Yes, thank you.
Great. We're doing, if I don't recall wrong, we're doing perfectly on time.
All right.
So remember, this conventional diagnostic evaluation that we had to do in a conventional way, let's see how we can take all of this information in a digital way. And this patient and now friend of ours, she came to us while we were doing the residency. So we were just at the same situation that you guys were in right now. Her name was Sonia. She was a dental student that as she went through the classes of dental school, she realized that her smile was not ideal. And she was self-conscious about her smile and wanted to improve it because she showed her gums too much. Same chief complaint as always. So when these patients come, you'll start seeing these situations and they will start resembling one case to another. And first, let's ask ourselves question. Question number 1, does the patient have short teeth? Yes, indeed, it seems like the teeth are short, right? But why are these teeth short? Does the patient have altered passive eruption? Well, let's just look at the phenotype of this patient. Look at the very thick, soft tissues. Look at those clinical images compatible with tori in the posterior. Look at those short anatomical crowns, but we still don't have definitive answers. So, does the patient have a gummy smile? Well, that's pretty evident, right? But what's the etiology? Of course, in most of the cases, it's going to be multifactorial, but does this patient have altered passive eruption? Is there anything that we can do to her as periodontist, or should we just tell her to get Botox every 6 months to correct her smile? Well, this is when we like to start with the digital planning phase. And this, we're going to do everything in a very simple way by just obtaining 2 files. From a CBCT, we're going to obtain the DICOM file, which, as you can see, gives us information about the hard tissues. And from an intraoral scan, we're going to obtain an STL file, which gives us information about the relationship between the gingival margin and the exposed clinical crowns. And what can we very, very, very easily do in any software? Superimpose these two files, the DICOM file and the STL, so that if we go through our slices, we can see exactly the whole second part of the presentation, which was the importance of the direct relationships between those anatomical structures. We can see where the gingival margin is. We can see where the CJ is, and we can see exactly where the alveolar bone crest is. Not only that, we can measure exactly the distance between these anatomical structures in every single tooth. So we know exactly how much we can lengthen these teeth, and we know exactly if we need or not to do osseosurgery and how much osseosurgery we need to do. So now with this information, remember how hard it was initially, and we were not able to precisely do a proper diagnosis. We can diagnose her individualized way as an altered passive eruption type 1B patient. And this is not too new. This is just digital diagnosis applied to aesthetic crown lengthening. This had been published before by the group of DSD led by Christian Coachman. However, we also wanted to improve the patient communication phase because we felt that whenever we are going to change the smile of a patient with veneers, we always do a wax up, right? So why, if we're going to change the smile of the patient with her own teeth, should we not show the patient the result beforehand to see if they want to go for that process or if they want to keep their gummy smile that gives them personality? So now this used to be very modern 4 or 5 years ago when we published it. However, this is very everyday practice. We can do AI-driven tooth segmentation, which allows us to obtain the exact shape of the teeth of the patient. And based on this, in a lab or somebody that has more ability with CAD softwares, we can turn this into veneers that then, with a 3D printer, we can print them and test them on the patient. We can test them on the patient to see those 3 millimeters that we saw in the CBCT that we can lengthen. We test it, we place it on the patient. And this was the first patient that we did, the first prototype. So as you can see, the veneers look like chewing gums. Now we have better materials. Now we have more thin veneers. However, the effect is there. And not only that, we can test it on the patient in a static and also a dynamic way. And we can show the patient the expected result that we're going to get of the surgery beforehand. Because remember, gummy smile has a multifactorial etiology. So if we only correct the altered passive eruption, we will improve her gummy smile, but most likely not completely solve it. So once the patient approves, what we do is create a surgical guide to help us and guide us exactly cut the tissues where we want them and exactly go to the CEJ of the teeth so that the surgery becomes very simple and very predictable. And now we're going to see the surgery in detail. We're going to skip some parts. However, we're going to see here the initial situation of the patient with very short teeth. And these are the veneers that we use intersurgically to check and to test the end result beforehand. Remember the situation and check how they will look at the end of the surgery and where the gingival margin will be. Of course, we need to apply some anesthesia. And once we apply some anesthesia, you can see here perfectly the difference between regular probing and here bone sounding. See, we have 1 millimeter more. So that means that our bone is only 1 millimeter away from where our probe is going with our regular probing. So of course, we're going to need to do osseosurgery. However, what do you think is more precise, this measurement or what we obtained with the CBCT? And now we can obtain the surgical guide, which will guide us in our gingivectomy and mark exactly where we want to perform our gingivectomy, which should be, remember, 3 millimeters. And here we're checking that every step of the process is working and is streamlined. Here we used a very old school electroblade. We are a public school at University Complutense of Madrid, and the one laser that we had in the school wasn't available that day, so we had to go for the 19th century electroblade. However, it does the work exactly the same, and we can see the precision that we have at reaching exactly the CJ. We remove the scallops. The advantage of the laser is that it allows you to pencil the gingival margin exactly how you want it and do minimal changes, and see how it exactly adapts to where we had those maps, which is exactly where the CJ of the patient is, because we did the AI-driven segmentation. Now we check that it's exactly at the CJ. Now it's very easy to detect. And now we're going to raise a full thickness flap, reach the bone. This part I'm going to skip because you guys are peri residents and this is very, very easy for you already. Make sure we have a full thickness flap. These flaps are sometimes harder to elevate because the tissues are very thick and very attached to the bone. And we carefully detach first the papillas, and then we elevate the flap all the way through. Depending on how much osteoplasty we need to do, we'll go past the mucogingival junction or not, and see how that bone is very close, is too close to the CEJ, which is not a surprise because we had planned that and we had diagnosed that initially. We test, of course, you don't need to test in a surgery so much. This is just for educational purposes. And when we have, remember, if we want to leave the gingival margin at the level of the CJ, remember what was the distance from the free gingival margin to the alveolar bone crest in general? 3 millimeters. So in these patients with a thick phenotype, we need to create that space for 3 millimeters for that reestablishment of the supracrestal tissue height. This is the ostectomy all throughout all the teeth. And now we go one side first and the other side. We'll speed through this. And see, these ledges will be created. We check you can do a double guide that has 3 millimeters on top to also have a reference. If not, you can just use your perio probe. And now we're going to do the osteoplasty, which is just creating an ideal anatomical contour, removing those tori, creating those interdental grooves, stimulating a natural anatomy of a patient with a normal bone phenotype. And once we have this and we are happy, see, we check that we have 3 millimeters on the CEJ, that the CEJ of our veneers matches exactly what we have. And once we are happy with the result, we proceed with the suturing. And I don't know if you guys know about this, but whatever we give to these patients, they're going to show during the follow-up. And to me, if we perform aesthetic plastic surgery, the immediate post-op result should also be aesthetic. So that's why I suture these cases with vertical mattress sutures with the knots in the palate. Because if you do this with 6-0 suture, you'll see the patient will not even be able to see the suture. This is great for your patients and horrible for your backs. So depending on how much you like the patient, you can do the suture or a more conventional suture. See, you go in at the tip of the papilla in the palate, you go through the buccal, tip of the papilla, then you come back at the end and suture. And as you can see, this is the final situation. The soft tissues are a little bit damaged because of that old school electroblade, but that will not make a difference. And you see exactly the adaptation of the gingival margin where we had planned initially. And once we check that everything's okay and we're happy with the result, with the desired length of the teeth, we tell the patient that everything's okay and that she can go home. And what results should we expect? In 1 week, we have a result that the patient can pretty much go to any party or any event with her desired final result a couple of days later. And you can barely see the suture. And this is the result at 1 month. But it's very easy to have a nice follow-up at 1 month, a nice result at 1 month. The merit is that this is stable over time and that we have the same situation 12 months later, which should be stable many years later if it's stable at 12 months. And the advantage of digital tools is that it allows us to also superimpose and check the result of our treatment. And here at the blue line, we can see the final gingival margin position, which we desired to be at the CEJ or 0.5 millimeters above the CEJ. So now we have the final situation of the patient, which looks exactly as what we had shown her with those multifunctional anatomical prototypes. And just for the last minutes, we can even go further now. We have different softwares that allow us with AI-driven smile design to create designs that will guide our crown lengthening procedures, whether this is going to be with the actual shape of the teeth or with restorative work. And just to see a couple cases very briefly, not as in depth as the previous one, of the combination of these new technologies. For example, this patient, this video that we saw earlier, we can see how she does have a gummy smile. We perform the complete diagnosis in the software and see, remember the structures that were so hard to see initially, the CEJ, the alveolar bone crest, and the gingival margin. Here we can combine them all into already our digital software, and we can show her, look in the left, the result that she's going to have in the future. And here, remember how much of a headache it was to determine the relationships. Here we can see exactly based on segmentation, and look how nice it looks and how evident it is, the position from the CEJ to the alveolar bone crest to the gingival margin, to the final desired gingival margin, the final desired tooth shape, and here is my final guide. So in one same software, I have all the diagnosis, patient communication, and treatment planning and execution steps. And once again, all based on a proper diagnosis of the tooth length and all based on a proper diagnosis of the supracrestal tissue height. Then we just create once again the veneers. As you can see now, we make them much thinner and we show the patient this end result. And how do you think this patient is not going to accept this treatment if you show her this video? She's a beautiful patient. She had a slightly gummy smile, but look how much her smile and her face improves just with a very simple treatment. So now we can also use these maps to guide us to the surgery. We don't need to have a full-on guide. If you're not a fan of guides, we just wanted to show, for example, you can mark, you can go freehand. There's different ways you can do this treatment, okay? This is another surgeon, which as you can see, we go to the CEJ, we elevate the full thickness flap, we test, we do the osseous surgery, same exact steps as before, ostectomy, osteoplasty, and then we suture with the knots in the palate. And baseline situation, final situation, 1 year later. Look at how the smile changes for the patient and how stable it is 12 months later. This is a baseline situation, and this is 12 months. And like I said, digital technologies also allow us to check our results and be very critical with our results. And this is a heat map showing the change between the two different intraoral scans. This is between baseline and 3 months, okay? So look at that change, how we've lengthened the teeth significantly to the level of the CJ. Red means that there's been no change. But if we change from 3 months, look here, from 3 months to 12 months, look at the change. There's been absolutely no change. It's all red. So that means that the gingival margin is completely stable. Why? Because we performed the surgery guided digitally and biologically oriented. This we've already published this together with other contemporary digital protocols, like for example, tooth autotransplantation, guided implants, etc. And as you can see, these protocols can also work for more simple cases in which we just need to do gingivectomy, or for more complex cases in which we also need to do some, for example, direct composite restoration, or a case like this, much more complex, where we need to do significant veneers, ceramic veneers. Very slight cases of asymmetries like this patient, a very beautiful patient with a very slight asymmetry. I want to really make sure that I get the best exact result and that I go directly to plan and to execute exactly where I want my future anatomical references to be. So here, once again, is the same process we saw earlier, but now we're just treating one side, as you can see here, because we want to make her smile symmetrical. And I'm going all guided based on her anatomy. I create a template so that I can use in the surgery. And once again, these maps, look how good they are now, how much better they are than the previous ones, to show the patient the expected minimal changes that we're going to do in her smile, so that we can use them for step 1, gingivectomy, step 2, osseous surgery, and we can get such a predictable result as this. And with this, I think we finish the presentation. I had another case, but this is more related also to implants, in which I just wanted to show you that all of these protocols, we can also use them in cases in which we're missing implants, when we're missing teeth, And we also might be needing to do some sort of implants or guided bone augmentation. And as a final take-home message, it's 6:49 in Spain, 12:49 in New York, so I'm perfectly on time, is that digital workflows can help us during the phases of diagnosis, treatment planning, patient communication, and surgical execution to help our treatments be more predictable. And always remember, periodontology can be slightly tough and stressing, so predictability means success in your day-to-day practice. Thank you very much for your attention. Here's my, I put my email before, but you already have it. Here's my social media in case you want to share anything or ask me anything in the future. And I look forward, hopefully, to a nice round of questions and discussions. Dr. Shin, I think you are, I think you're muted.
Sorry, so I was running 5 minutes late. I'm sorry about that, but we can have 5-minute Q&A at the end, but can we look over that implant case for 5 minutes? That looks really exciting. Interesting.
Yes, will do. Give me a second. I will share my screen. The case, I don't think I have it finalized in this presentation, but I just wanted to show the possibility of combining. Yes. So can you see the screen now?
Yes. Thank you.
So what if we have, and this is something that we're looking into now, because we see many conferences cases where they place implants in patients with ultrapassive eruption. It's something that they oversee. And then once the implant is placed, we have nothing to do about the epidural position of that implant. And it might already be too late to treat the adjacent teeth. So when we have cases like this, for example, this patient, Chris, he lost a central incisor playing basketball. We started treating him last year at the University of Michigan. And of course, he's self-conscious also about his gummy smile. He wants to do a comprehensive treatment. When we plan implants, of course, we need to start by the tooth, the 3D prosthetic design, then plan the implant position, and then the 3D position of the implant. So we need to think one step ahead. If we're going to place the epicoronal position according to the gingival margin position of our crown, if we want to change the gingival margin of the adjacent teeth, where is the gingival margin of that crown going to be? Because if we design it similar to the adjacent one, to tooth number 9, we're going to be in trouble in the future. So thus, once again, what we do is based on AI segmentation, plan to the level of the CEG of the patient, the crown lengthening that we're going to do, so that then we can design a symmetrical crown, create first that crown lengthening, and based on that reference, we try to plan the position of the implant. So just applying the same exact protocol, but to this patient that has a missing central incisor. And here, based on that, we have the crown, we plan the position of the implant, and what becomes evident is that the ridge is too narrow to place this implant. So we have an added layer of complexity, which is that we need to do a GBR. So we need to do crown lengthening, gingivectomy, osseous surgery, GBR, implant placement. That, if we go step by step, that's going to turn into so many surgeries, and the patient is not going to be too happy. But we have all the technology and all the knowledge to try to do the best treatment possible for our patient, and also as predictable as possible, and minimize the amount of surgeries. So remember, in crown lengthening, we have a hard tissue component to fix, also a soft tissue component to fix. And when we place implants, we also have a hard tissue component, which is doing a GBR and placing the implant in the ideal position, and then a soft tissue component to deal with emergence profiles, soft tissue grafts, etc. So why don't we combine all the hard tissue components together, and we do the osseous surgery at the same time as the GBR? If we wanted to also do the gingivectomy, it will be a little bit counterproductive, because we're taking out soft tissue, which then we need to have primary intention healing on a properly done GBR. So since we have all the 3D data, why don't we help ourselves? And this is not completely mandatory, less when we're using collagen membranes. It can be much more helpful when we're using non-resorbable PTFE membranes. But why don't we help ourselves to make the surgery more predictable? Raise a flap like we did here. We raised a mucogingival style flap because we were not going to do the gingivectomy at this stage. We did with the maps, as you can see here in the bottom left, the osseous surgery for the crown lengthening. And then we also did the horizontal GBR. So that then on the next stage, I'm not even going to need to raise a flap because I can just do gingivectomy and place my implant flapless with guided surgery into hopefully that nicely regenerated bone. And this is a very nice paper. I recommend you guys to read it by some of my ex-professors and now colleagues, Oscar González Martín at University Complutense of Madrid, of two-stage crown lengthening, which means that first we do the osseous component, we close the flap, the gingival margin will pretty much go to where it belongs, and then you'll need to do in a second stage just gingivectomy. And in this presentation, sadly, this is all the follow-up that I have because it's not the main, it's not about implants. I just wanted to show the combined treatment, but this allows us to have very predictable results of both soft tissues and look at the nicely healing volume of bone that is healing underneath that provisional. So I don't have the final result here in this presentation, but hopefully if I'm ever back in Colombia, we share any other sessions, I can share them with you.